Welcome to Washington Hospital Today, the program dedicated to sharing timely information about the community hospital that's been taking care of Washington Township Healthcare District residents since it opened in 1958. Washington Hospital Today is provided for the sole purpose of informing residents about healthcare topics and issues that have been covered during community forums, free health and wellness classes, or as part of educational sessions held during the district's open board meetings. This program is one more way that Washington Hospital helps empower you, the residents of the district, by providing information needed to make informed decisions about your health.
What we're going to talk about today is plantar fasciitis, and plantar fasciitis and heel pain especially is something that plagues lots and lots of people. It's something that is present, and the thing is that there's a statistic that says about 1 million people per year are treated for heel pain. Of that, about 15 to 20% are treated for what we call plantar fasciitis. Now, we're going to get to plantar fasciitis, and that's going to be something that we'll spend most of our time with, but I think we need to clarify a few little things, along the way, so that what we're trying to say to you is that not all heel problems are plantar fasciitis. And to effectively treat something, you have to know, what you're treating, so that you get the results that you want. And what we're going to try and do today is to teach you how to be a foot doctor treating plantar fasciitis or any type of heel pain. I got to tell you a joke. Abe told me to tell you a joke. And did you know what the fish said when it ran into the concrete? Damn. Anyway, now in this scenario here, you wouldn't run around the freeway, on flat tires. You'd be a very nervous individual. And the thing is it wouldn't make good common sense, because you know that this is what's going to happen, and this is going to be the disaster that you're going to have. So you've got to be careful with your feet. I mean, you treat your tires and you get worried about the freeway. Then also when you start to have pain and discomfort in your heel, you want to be concerned about what's going on, because pain does indicate that there's something that's not right. And you don't want to ignore that low pressure tire that you're going to go on the freeway. So why do you tolerate that low pressure pain or that low degree of pain? And so what we're going to say is that you don't want to ignore that. You want to take and treat that, on a home basis, because this is going to decrease the damage that you're going to have. And you can do a few very simple little things that'll help you to a great degree. So everyone has a cure for heel pain. If you tell somebody you got heel pain, they're going to tell you they've got 30 million different cures for it. So the reason for that is that we all have different problems, and different problems require different treatment programs. And so basically, we treat today about the same as we did 30 years ago, and one thing doesn't always work, because, like I say, we have different foot types, we have different foot problems, we have different structures, and also biomechanically we're different. We walk differently. And so the thing is, we have to take all of these things into consideration when we talk about foot problems. And there's no magic out there. There's no magic cream, there's no magic shoe, there's no magic nothing, because basically it is such a, we're trying to lump one problem and one solution when there are many contributing factors. And so what we want to do is we want to know that if you treat early, then the thing is that this will shorten the length of your treatment program. There's almost a one-to-one relationship. If you have this thing for 4 to 6 weeks, it's going to take you 4 to 6 weeks to get this thing to heal up. If you have it for 4 to 6 months, it's going to take you 4 to 6 months to get it better. And the reason is that you have a relationship that it causes trauma and damage to the area. And so there is a common factor that when you do go barefooted in the home, this is something that causes trauma to the heel and aggravates the condition. We have compression of the arch, in which the arch kind of lets down, and basically when your foot kind of pronates and goes flat, this causes problems to the foot. We do know that flat shoes are a contributing factor, and that we on hard surfaces are a contributing factor. So we have to avoid these situations by not going barefooted in the house, by avoiding hard surfaces to walk in. You want to wear comfortable shoes that create cushion to the bottom of the heel, because again, this is a progressive, ongoing micro trauma kind of a thing that we need to reverse as early as possible. And also that biomechanics is the factor, probably one of the key factors in it. So like we talked about before is that when we treat this early, and this is why it's important for you, when we treat this early, we have abundance of healing tissue that the body throws out. And so during this time, you can maximize your treatment by treating it by yourself at home, by doing a few simple things to help slow down the deterioration process that generally occurs with heel pain. So what we're saying is that if you jump on this early, you get after it, you start to treat it, you're going to shorten the length of time that it takes, and that generally is the case with most heels. Most heels take a long time to heal. They take anywhere from 4 to 6 months to heal as an average length of time. So if you can treat it early, then you can reverse that process and help the problem considerably, because you have an abundance of healing cells in there to kind of maximize your healing. As time goes on, the body does not throw out those healing cells, and so it stops the healing process to a certain degree. And so you're running, or you're trying to heal on a very few cells to heal this. And so that's why it's important for you to treat it early, to get after it, and to maximize the healing process. There are certain areas of the foot that have certain conditions, and we'll go over this. The back of the heel is the tend to Achilles area. Here we'd have a spur. The typical, most commonest one is plantar fasciitis, and then also we have the bursal sac. Now we break heels down into 5 kind of conditions. There's traumatic, neurological, arthritic, and then a soft tissue, and then we have mechanical. Now remembering the mechanical is the most commonest. When you step down on your foot and it goes flat, that's the most commonest. Now what we're going to do is take each one of these just a little bit. So the idea of it is this: if I tell you a few little things to look and watch for, you won't go in and treat this heel as a plantar fasciitis. You'll treat it accordingly to what the problem is, and you'll get a better results. So if you have a traumatic heel injury, then you're going to have the typical, you're going to know you injured it. It's going to have global kind of pain and activity, or as you walk, it's going to get worse. You generally can detect that by x-ray, and you do the typical treatment of rest, ice elevation, and immobilization, and basically you'll see it as a fracture on an x-ray, like right in through there. Neurological is a compression type of a problem. In other words, a nerve is being compressed, and generally you have radiating pain, excruciating type of pain. It's numbness, it's burning. You generally have to diagnose it with certain studies, but the typical thing is this radiating, horrible kind of pain, almost like a person gets with like a diabetic neuropathy. Our most commonest one that we'll see in the heel is what's called a tarsal tunnel. This is where it's compressed, or the nerve is compressed. It radiates pain back to the heel, and so you have to treat this accordingly. Generally, you have to release these nerves. Another one is there's a nerve on the side of the foot that will get compressed and cause pain and discomfort, and that's this nerve here, and then it'll simulate like a plantar fasciitis to a certain degree, but it's more of a nerve problem, and you have to treat it by releasing it. You have to release the pressure off of the nerves to make the nerves better. Also, a person who has a back problem or a sciatica, this causes referred pain to the heel. And again, you have to generally refer that out, or you have to see, a neurologist or see a podiatrist for, correction of that problem. In arthritic heel pain, you're going to have inflammation of other joints. Generally, you can detect this with lab studies and x-rays. The most commonest one here is rheumatoid arthritis, gout, psoriasis, the common fibromyalgia, Reiter syndrome, and sickle cell anemia. These have to be treated individually, and generally you have to treat those medically. And then, of course, the ones that we see, and that you'll see is like bursitis and tendinitis. You may have some infection and some vascular. All of these can cause pain and discomfort in the heel that would lead you to believe that there was something wrong. But again, you have to treat that individual problem. Like if it's a tendinitis or a bruising of the heel, you have to kind of, put some ice on it and treat it accordingly. So I think what we're saying here, also one other little thing is that we have bursal sacs in those heels, and they in themselves get inflamed and sore, and also tendinitis. And what we're saying here, just to kind of clear it up for you just a little, because is that we have traumatic, neurological, arthritic, and soft tissue, things that can cause you problems in the heel that are a little bit beyond your control. You can't treat those as effectively as you can some of the mechanical ones. Now, we're going to spend the time on the mechanical ones, which is primarily plantar fasciitis, but we needed to identify the fact that if you're treating this and it's not going well and you don't get a response in 1 or 2 weeks, then what you want to do is you want to look at it or go see your family doctor and or podiatrist. So mechanical is the one that we're going to spend the time on, remembering that this is the most commonest. This will occur probably 50% of the time. And of those two, there's plantar fasciitis, which is the culprit. This is the one that we most often see. The other is what we call posterior or insertional problems. And the reason that we get this plantar fasciitis is that we have a high arch foot structure here in both of these individuals. And when they step down, that foot stretches out. And when that foot stretches out, I'll show you a little bit later why the plantar fascia is the problem. What happens in the plantar fascia is it becomes overpulled. Now, you take a person who's flat-footed, their feet are naturally under stress. And I mean, if you can't ache and hurt for this person with the type of flat-footed that they have to walk on every day, and the maximum amount of stress and strain on those tendons and ligaments, it's, I mean, I'd hate to have that, because the thing is that every step you're labored. And the fortunate thing, or not necessarily the fortunate thing, but the thing is that we see individuals most commonly with high arches with foot problems, or high arch people produce more heel pain than anyone else. That's a better way to say that. So we have the two types. We have the back of the heel and we have the bottom of the heel. And what we see in those two is that when we talk about posterior or back of the heel, these are a little bit more chronic. They take a little bit longer to develop. They are kind of more nagging in nature. Once in a while you'll have what we call an insertional problem, where the tendon where it inserts into the back of this heel gets inflamed and sore. And we've all heard about tendinitis or tendo-Achilles tendinitis. And so these are problems that affect the back of the heel, where there's an overpull, there's a formation of a spur, and these become very painful and sore. This is what we call Haglund's disease. This is a kind of a bone spur, but this also has that pain with the tendons where they insert, where there's an overpull, the tendons become inflamed and sore, and then we have the typical tendinitis with the bone spur. This is what that individual looks like. They have a large bump on the back of their heel, so they have a hard time, wearing a closed-in shoe without a lot of pain and discomfort. This is what their x-ray will look like. They have a large bump on the back part of that. And this individual here really has a bump on the back of their heel. And what happens is the tendo Achilles attaches into here. And the thing is that you just can't put that shoe on through there without a tremendous amount of pain and discomfort. And you'll also get a lot of tendinitis right back here in the back. And see, also then the bursal sacs will come into play. And it's located right in through here. The other kind of a heel problem is a Sever's disease, or what we call, this is kind of a childhood or child problem. This is an active child's disease, and where there's an irritation to the growth plate. And the thing is that what they do is they complain about, like when they go out and play and then they sit down and then they start to get up and walk again, they have a stiffness and soreness, and they have a hard time running. So they have a tremendous amount of pain back in the back of that growth plate. And generally what that is that's a result of the arch kind of giving way. So we treat this by putting them into an arch support and elevating the heel. Now, what you can do for back of the heel problems, we're talking about back of the heel problems, is you can elevate your heel. And this is something that you want to do. So if you have pain in the back of the heel, what you want to do is elevate your heel. You want to get orthotics. You can get over-the-counter orthotics. You can wear, again, the open back with the elevation. You can take something like Advil or Aleve. And the thing is that you can do physical therapy by decreasing the amount of activity that you do. If you don't pull on it, it's not going to hurt, especially there in the back. And I think the other thing that's important is an accommodative dressing. So you're going to wear an open back shoe that's elevated, that's not going to put any pressure. But let's say that you have to go somewhere and you got this large bump on the back of the heel and it's painful. What you do is you get a piece of felt, you cut a hole in it like a donut, and you stick it on there on the back so it doesn't rub. And so that's like wearing the open back elevated heeled shoe. What you're going to hear, the repeat message here is with heel problems, is that if you soften the heel and you elevate the heel, then that's going to make and lessen the amount of pain that you have. And that's what we're saying here. Now let's say that you do all of this and it doesn't work. You elevate the shoe, you wear all of the elevation, the steroids, put ice on it, do all of these things and it doesn't work. And let's say that you're into it about 4 to 6 weeks. Now, if you're not getting better after 1 to 2 weeks, then go see the doctor. If you're into it 4 to 6 weeks and it's still not getting better, go see the doctor. And there are things that we do basically that are more, they're more severe types of immobilization, like casts and what have you. But for you, I think that if you follow that simple rule, and do those simple things, what you're going to do, like we talked about initially, is you're going to take advantage of this nutrient or this healing cells that are inside of your body. You're not going to ignore them during that time, and you're going to utilize them during that time so that you maximize your healing. Because what we want to do is catch it early. We want to maximize our healing. And so if you jump on this and not just get up in the morning and say, well, my heel hurts, it's going to get better tomorrow, you want to get in there, you want to elevate the heel, you want to wear a soft shoe, you want to do all of these things that we talked about so that you maximize your healing ability. But if it doesn't work, then you go and see the doctor. Now, there's always the question of with heels and the back of heels and the bottom of the heels. Most people have the feeling when they come into the office, well, just give me a shot of cortisone and I'll be back on the road again and I'll be okay. That's okay with certain conditions. However, there are conditions that you don't want to inject. I think that what you do is you need to know what you're treating, and that's the reason we talk about the neurological, the arthritic, the mechanical portions. We need to know what we're treating so that we can maximize our results. So if you go to the doctor and you have to have an idea a little bit ahead of time, of what works and what doesn't, and why you get the shot and why you don't get the shot, because the shot does work good in certain conditions. It'll knock it right out. Now, it does well with bursal sacs. Like I said, that bursal sac in the bottom of the heel, it works excellent with. It works great with tarsal tunnel. And if a person has a chronic swelling, or you have an intra-articular or within the joint, it works very well at that point. However, you don't want to inject tendons because you're going to rupture it. You don't want to inject the bottom of the heel in the plantar fascia later on in that 4 to 6 month period of time, because you only have minimal cells to treat and heal, and then you go in there and put cortisone on top of it. It's only going to heal this, or it's going to slow the healing process down by that much. And we call that fasciosis, and we don't want to stop the clock, so you have to be careful there. But it does work well in bursal sacs. Now, we've worked hard to get to this point. This is our point right here. This is called plantar fasciitis. Now, plantar fasciitis is probably, you can, if somebody has a heel pain, you can say, oh, you got plantar fasciitis, and most generally you'll be right with that. Now, how you tell it's plantar fasciitis is that generally after you've sit down and had a rest, or you've gone to sleep at night and wake up in the morning, there's a stiffness and a soreness, and you feel like you're about 90 years old when you first get going, and then later on, as that loosens up, then it feels better. And what happens down there is that the cord on the bottom of the foot, you get inflammation and soreness down in here, and also that little bursal sac can form down in there. Again, this is the one that would respond to that cortisone. Now, this is a heel spur. I want to tell you about heel spurs. Now, heel spurs in plantar fasciitis, we'd go to the doctor, we'd take an x-ray, he'd say, oh, you got a heel spur, and the next day you were in the operating room cutting the heel spur out. We don't cut heel spurs out. They have nothing to do with the pain and discomfort that you're having in your heel. Not all the time, but maybe 1 or 2% that they do. But the majority of the time, it's strictly a tearing of that plantar fascia. And whether you have a heel spur up here doesn't matter. Because we see every day x-rays on people who have large heel spurs who have no pain in their heel whatsoever. So heel spurs are nice to look at on x-ray. They're great to see, but they really don't mean anything. It's really the plantar fascia that's the problems, with or without heel spur formation. It's the actual tearing of that fiber in there, and that's really the critical thing. And that's the one that you'll see most of the time. So let's say that we have a heel spur or we don't have a heel spur, doesn't matter, okay? But what's important is here in the bottom of the heel, what we call the plantar fascia, which attaches here in the heel, it fans out to the ball of the foot and then back to the heel. Now you can see that there's a tremendous width here with a small area there. Well, because mechanically there's an overpull on that area, and especially we said that as a person's foot stretches out, either because of their foot rolls too much or pronates too much, it stretches out. So you can see that as that arch here goes down, or in other words, as stretches out, it maximally pulls right there. Or here's another picture of the same thing, and it starts to tear. And we get a micro tearing of that plantar fascia. As time goes on, it just continually tears and causes the pain and discomfort. So what we're saying here is that with a flat foot, it stretches the plantar fascia. With a high arch, it stretches the plantar fascia, but we see more of the plantar fascia in the flat foot, and that's because that foot rolls out and causes the pressure. So what do you do if you wake up in the morning and you kind of feel like you're about 90 years old, and then you finally get it together and then it feels pretty good, and then later on in the day then you start to get this heel, this achy and this nagging sensation in the bottom of the heel, and it's generally on the inside part of the arch, about right in through this area, right in through here, what do? You say, well, I think I'll wait till tomorrow. It might be gone by then. And then the next day I keep saying that, and I keep saying that. And about a week later, I got this thing I can't even hardly get up in the morning and step down on. So what you need to do in a case like this is you need to jump on this. You're not going to hurt yourself any, or you're not going to hurt the condition any. And the thing is you want to get after this right early. So I think what you want to do is, number one is avoid flat shoes, and also going barefooted around the house. That, again, is the most commonest element that we see, and in questioning after questioning and survey after survey, people who have heel pain and plantar fasciitis spend too much time barefooted in the house without shoes. And so you have to avoid that. You want to use some ice on it. You want to get a over-the-counter cushion, or you want to get an arch support. You want to limit your activity. You want to take anti-inflammatories. I'm going to show you how to pad and strap your heel. And then you want to do some stretching, but the stretching you have to be a little bit careful with. But if it hurts, don't do it, kind of a thing. If it doesn't work, then you go see the doctor after 4 to 6 weeks. If you're into it 1 or 2 weeks and it's not getting better, then go see the doctor earlier. Don't put it off. We have to maximize that energy and those healing cells. So if you go see the doctor, what he's going to do is give you some anti-inflammatories. He's going to immobilize you. If you come to my office, you're going to get tape. We're going to manage your control with your shoe and orthotics. Orthotics should be a little bit on the soft side to start with. And then later on, you could do some heel cups in certain shoes. He may do some physical therapy, like some ultrasound, hot and cold. He'll advise you on the shoes. And basically what we want to do on the shoe is you want to elevate the shoe and soften the top part. And if you don't get better, he's going to advise some surgery. So remember what you can do early. Remember, it's that if it hurts, then you don't do it. Let's say if you're out walking and it hurts, don't do it. You use ice, elevation, or rest. You go no barefooted. Cushion the heel. You want to elevate the heel. You want to go to a soft shoe. You want to take anti-inflammatory medication like Advil and Aleve. You want to avoid the gimmick shoes. You want to do some stretching. The tendo Achilles stretching and what we call Billings exercises are great, and I'll show you how to do those, because those are great ways to take some of the heel pain and control it. You want to discontinue any impact exercises. You don't want to climb the hills or do any jogging or anything like this, and you want to stay on soft surfaces. You can get an over-the-counter arch support. And then again, you want to rotate your shoes. One of the things that will help you a lot in dealing with your heel pain is you want to rotate your shoes, because sometimes that pulls differently on different muscles. So what we're saying here is when you get the heel pain, you bring out the ice pack, you elevate the heel, you go to a soft running type of a shoe, you take some Advil or Aleve. And the thing is that you can also then go look at over-the-counter arch supports. Those are also helpful. If it doesn't get better in a period of, say, 4 weeks or so, but it's progressively getting better, then go ahead and stay with what you're doing, because it's working. This heel is not going to get better for 4 to 6 weeks, and in some cases, 4 to 6 months. These are they have very poor healing, and that's why you hear so much about them. Now, some of the things that you can do a little exercise, like you can take a ball, like a racket ball, and roll it around on the bottom of the floor. You can exercise by taking a towel and putting on there and kind of crinkling it up. These are sitting exercises. This is the tendo Achilles stretching, and I'll show you this a little bit more. This is one of your better stretches and the one that'll help you the most, especially with that plantar fasciitis. You can do some hamstrings exercises, and if let's say that you can't get down to your feet, or you can't do any standing, then you want to stretch it. Now, this is an exercise that I say, well, be careful with this, and this is standing on the edge of the stairs, dropping your heel down and then bringing it back up. Be sure you're hanging on to something, and I think later on, as you progress and more of a preventative on the long-term basis, this may be a good exercise for you. Now, tendo Achilles exercises are great for people who have plantar fasciitis. So let's say that you have plantar fasciitis, your heel hurts. What you do with it is you get next to a corner or a counter, and what you do with it is that you bend this one knee. Let's say that we're going to stretch our left one. What you're going to do is you're going to bend this knee like you're hugging up next to the counter, and then you stretch down on it. And what you're going to feel is a lot of a pull in the back of the heel, and you just kind of stay down on it till it kind of hurts a little bit. Then you kind of come off of it. Then you kind of do it again. Don't let your heel lift up. If you let your heel lift up, then that's defeating your what you're trying to do. And then you do it on the other foot. The same way is that basically you're bending your knee so you can get closer to the counter. You're keeping the back foot straight so it stretches the tendo Achilles. If you have any doubt about pain in your heel, and if you do get pain in your heel, try that little exercise. Another one that's very good, but this is more for a sciatica, is you cross the leg like this. In other words, you take and just kind of put one foot in front of the other. You kind of cross it like this and put your heels close together, and then you come down. Be sure and hang on to a thing. And then you come down and touch your toes, and you just kind of stay down there for a little bit. Sounds like I got a high-pitched voice, right? And you kind of come down here like this and kind of stay down there. And what it does, that causes a stretching on the sciatic, and what you're going to feel after you have it, you're going to have a hotness in your heel. The heel's going to be just really warm. But you do that a bunch of times. Let's say you have pain in your heel, do that, and it's very helpful. And it will take sometimes when your heel hurts, you can take that pain away from it. Those are Billings and tendo Achilles, and they're both excellent. Now, what we're saying here is there's a few little things that you can do with your, here you can take and get a round plastic bottle, put some water in it, put it in the freezer, and then what you do with it is you take it out of the freezer and roll your foot back and forth on it sometimes, and that's kind of a way to kind of preventive or improve or take out some of the swelling and improve the flexibility of the foot. These others you can do like passive exercises. Now the passive exercises are really important. Let's say that you have pain in the morning. When you first get up, you want to exercise your foot just a little bit to kind of loosen it up. And basically it's just moving it. If you sit down for a length of time, have lunch, before you get up and step down on it, what you do with that is you passively exercise it. If you're at the sink, a lot of times standing in one place is very painful and discomforting. So what you do is while you're maybe cooking dinner or washing dishes or something like that, you just kind of come up on your toes, and that helps to exercise and keep those muscles going. Again, we're back to the don't go barefooted. Now, something that I use tremendously, and I have a great value for, is called taping. And if anybody ever came to my office, they know they're going to get taped. So the thing is, but it works. Now, the NFL is a prime example. They pay these guys millions of dollars to play football, and the thing is they have the best of doctors, they have the best of everything, and the thing is, what do? They tape. And every year, they got these guys on the side, with plantar fasciitis. Every team has 2 or 3 people who have plantar fasciitis, and how do they treat them? They tape them. They don't do anything other than taping and give them a chance to rest. So if they've got millions of dollars and they're taping, then me with a couple of dollars, I'm going to tape, and it works. It's probably the thing that's been around for 30 years, and it's the one thing that will consistently help a person who has plantar fasciitis. So what you do with that is you take about 3 strips of 1-inch tape, and you start at the ball of the foot and you run it around the heel, and you do that about 3 or 4 times. What you're trying to do here is you're tightening the arch. You're trying to jack up the arch. And then over on the other side, you bring these little strips that are over here, you bring them back over to here and put them on the outside of the foot. All you're doing is just circling the back part of the heel. And basically what you're trying to do is shorten the arch. The arch is like this, And if your foot is stretched out and it's pulling on my plantar fascia, then if I jack it back up again, I'm going to take the pull off of my plantar fascia, and the plantar fascia is going to feel better. It's like putting my arm in a sling. It feels better in the sling. This is the sling that's going to make it feel better. So then after you put these on there, and these are 1-inch strips, just adhesive tape, then the thing is that you put about an 1.5 inches to 2 inches over here, and what you do with that is you create kind of a basketing of that foot, and the thing is you cinch it up. You're kind of cinching this thing up so that it takes the pull off of this plantar fascia, but also it cups the heel, and we get a cupping of the heel as well as the taping. And this is what it looks like, is these are the strips around the bottom. They're then put across here like this. You put more across here, and then this is what it looks like when it's through. Now yours is not going to look that good, but if you do get heel pain, you jump on this way, you'll never go wrong, and in most cases you'll be right, and it'll make your foot heal really, it just takes the pain away. And so then you can become functional, you can do what you want to do, you can walk, and then if you wear it in conjunction with either over-the-counter soft arch support, or you get a tennis shoe, this works. And this is why the NFL uses it. So be as smart as the NFL and use this, because the thing is it does work. This is probably the one thing that is of the most value that I have in my practice, because I learned to tape years ago from the experts, and I use it, and it's an invaluable tool. And I say, you come to my office for heel pain, that's what you're going to get. You're not going to get anything else, and you're going to get that. And we're going to put it on for you. But think of it, it's putting your plantar fascia in a sling. Now, these are orthotics. These are soft orthotics, and you can buy any of these over the counter. And what I do is do your taping, and then get yourself a pair of soft orthotics, and put them in your running shoes. And by doing that, then what happens is you create cushion and softness and elevation. Remember, we've talked about ice and rest and elevation like that. All we're saying here is we're going to tape your foot up, we're going to put you into a soft orthotic, we're going to have you wear a tennis shoe, and you're going to take and you're going to elevate this heel and take the pressure off of it. Now these are hard orthotics, and a lot of times you get hard orthotics, but you want to not use orthotics initially. The reason is they're too hard against this miserably sore, painful heel that has plantar fasciitis, and you're stepping on that inflamed area. And so you want to use these later. These come in handy. The other thing that you can use is you can use a soft cushion. You can buy this, a Big 5. This is made by Spinco. This is a 1/4 inch foam or kind of a neoprene kind of a pad. Here's a sock that you have that's closed, and this is a closed-in heel sock. Heel cups work, and heel cups with silicone work. Silicone is a new thing that's out that's really beneficial. The best shoes for you are the good old running shoes, the ones that have, the shoes today are, a lot of them are a little bit too thick in the sole because they have adapted, but the one that did all the research is this one here. Basically, it has a more soft and flexible heel. It has an elevation, it's soft, you got a rounded toe, it's got a high depth in this portion here so your foot can set down into it. One that works really well is this one here that's called Light and Easy. You can go over to Big 5, it costs you about $14 to $19. And during the time that you're treating it, this is a great shoe to have because it's inexpensive, it's very soft, it's elevated, and you can fit most of your orthotics down into that shoe, and it works pretty well. Now, if you're in Texas or you're in Utah, you're going to wear cowboy boots, because cowboy boots are the best thing in the world for you for plantar fasciitis. It fits all the needs, especially if you get one that's a little soft in the bottom, because it elevates your heel about 1 inch and a half. It has a counter in the back that squeezes your heel together to kind of compact the fat pad. And then also, it's a great shoe to wear. So, if you're in California, it's a little tougher. But the thing is when you get past that initial little bit of soreness and inflammation, basically you want to go to a cowboy boot. And then this is a sandal for women who are elevated, it's cushioned, it has a contouring bottom. Want to stay out of the flat shoes like the Birkenstocks, because basically when that foot goes from this position here, the arc is a lot farther than if I start from here and go forward. So the thing is, I want to help and assist that as much as I can, so I elevate the heel a little bit and also the cushion. These are too hard. You know, later on you could wear them. The big question is the NBA shoe or the Skechers. The problem is this is a gimmick shoe, and contrary to the stretching and all this kind of stuff like this, yeah, I don't want to step on anybody's toes, but the point is that this shoe is too heavy, it's too immobilizing. The back of the heel causes hyperextension of the knee, and the thing is there's no motion present in the foot. As time goes on, we need motion. If you don't use it, you lose it. So this is too immobile. Now the one thing it does help is if you have pain and discomfort in the bottom of the foot, right down in through here, it will help you roll over it. Now is this a bad shoe? No. It's a shoe that I would wear on occasion. I wouldn't wear it as a steady diet. It's too heavy, and it has these other features that don't allow your foot to move and function like it should. And so I'd say use it occasionally, you know, use it for a couple hours. You go someplace, you wear it. It's not going to bother you any, but it's awfully heavy, and that's the disadvantage. Now, I'm not picking this shoe out, but as you go along and you see, you're always going to see and hear about shoes that this shoe is the answer, that shoe is the answer. We haven't had the answer for 30 years. And so the thing is, it's not in a shoe, it's really into what you do and how you care for it and your biomechanics, like we talked about before. These are our night splints, and this is a cam cast. You'll hear those words. Night splints are what you wear, and it kind of keeps your foot stretched. This is what you go into in case you want to immobilize it. Now, what we're seeing here later stage, let's say that you've been treating this heel for 3 or 4 weeks and things are going pretty good and you're beating the odds, then what happens is things start to change. You know, the thing that worked before doesn't work now. And you get pain in different areas of your foot. It used to be on the inside of the heel, now it migrates to the outside. You know, you wear this shoe and it hurts. What it is that as a person gets better, towards the later stages of this condition, things change, and that's because you're using different muscles and you're compensating differently. So if this happens, is that if you wear this shoe and it's not comfortable, and then you go to another one and it is, the next day you get up and the one that was comfortable today isn't tomorrow, that's okay. You just go with it. In other words, you wear the shoe that's comfortable, you do the thing that's comfortable until you get past that late stage. We run across this in our treatment program. And the thing is that it seems to affect everyone. So it's a later stage, but it's because muscles are being used and adjusted. Now, some heels take a long time to heal. And we're talking about that 4 to 6 month period of time. And because the thing is that remember we said the early stage is fasciitis, and we have the repair tissue. And if we jump on that, if you get active in your treatment program early on, you preserve it and you help this fasciitis. But if you go past 4 to 6 months, your chances of healing are slim to none. And we even have a hard time treating it after that period of time. The reason is that you've ruptured what we call the ballases, and I'll show you. And where you've continued to tear the plantar fascia, or this is an ongoing tearing process. There's an over-tightness of the tendo-Achilles and the posterior tibial and all these muscles. Physiologically, splinting is occurring. And there's a change in the way you're walking, because if you're hurt, you're going to walk differently. And then because of the minimal or the ongoing trauma to the area, because it hasn't gotten better, it just progressively gets worse. And so that's a problem. Now, in the heel, there are what we call ballases. And ballases are little boxes. And they have, inside there, they have big fat cells. They have little teeny fat cells. They're all different sizes. It's like when the kids used to go to Discovery Zone and jump into the bin, you'd say, well, that's going to hurt, but they didn't hurt. And that was because they had little balls and big balls, and that took up the impact. Well, our heel is a Discovery Zone. We have little compartments in there, and in there they have big balls of fat, little balls of fat, so that when you slam into that heel at 65,000 pounds per square inch, which is 2.5 elephants on your shoulder, there's a tremendous force on that heel. Now what happens in a lot of cases if you let this go is you rupture the ballasine. And what happens is this takes forever to heal. So the ballasine rupture is a real problem. That's a later stage damage that takes us a long, long time. Now, I said to you we haven't changed anything in 30 years, but we have some exciting things on the horizon that seems to be working really well. And one of them is the ballasine that we talked about, basically supporting the ballasts so that they don't rupture. The other thing is what we call fenestration. What we're trying to do here is reset that clock. Remember we said 4 to 6 weeks or 4 to 6 months, it's gone. We don't have any of the healing tissue. Well, what we're trying to do here is we're trying to set that clock. We're trying to trick the body into resetting the clock. Prolotherapy is another way to reset the clock. And then what Benika described, what's called pain on pain. And what we do is we block out the pain that's causing some of the spasm and some of the other problems. Remember, time is the key factor. Of all of the treatment, the quicker you get on it, the less the length of the problem later on. So we talked about the ballast, the discovery zone, and the rupturing within this ballasine, and we want to try to figure out a way to preserve that. We want to set this clock back so that we can preserve this. And so what we do here is we try and compress the heel. That's why I think taping is so beneficial. You compress that and you reposition that fat. The fat is brought together back into it. It's kind of like hammering little boards on the side of the box, you know, of the discovery zone, so all of these balls don't go all over the floor. Well, we're trying to compress those or bring those back. We do it with a sock, you know, and this is something you can use. You can get over-the-counter arch or heel lift. And what we're trying to do medically is to recompartmentize that ballast. This is an exciting thing that's happening. This is a little bit of a surgery, but basically what it is that we make little stab incisions in the bottom of the heel. Let's say that you go past that 4 to 6 months period of time and you're not getting better. You've done your treatment program. You come to see us. We say, okay, you got to go in there and cut that heel spur out. That's going to be a 1-year recovery period of time. And you say, I think I'll live with it. You know, well, this is something that you can have done, and I've done it for the last several years. I've only used it on those patients that didn't get to better by conservative ways. You always have to remember, and it's probably only 5%, 2 to 5% of my patients. The rest of them, 80% get better conservatively. You do other things to get the other, 4 or 5 or 10%. But, in this procedure here, I think this is going to be one of the most promising things that come up because it's something that you can do on a very easy basis. It doesn't take you out of commission for a long period of time. It resets the clock. Remember, we want those healing tissue. We want to get Mother Nature back active into this. And so what we do is we make a little stab incision. We use 7 stabs because 7 is a lucky number. And this has been really great. Because this only takes you a few weeks to overcome. But again, when you do this, then you have to come back in and tape it for a few weeks because basically we're resetting the clock and it doesn't change the long-term treatment. The other thing that's promising is called prolotherapy, and that's where we take a 10% solution of dextrose, which is a higher than what you get, but it's just a little bit higher. We take that and we inject it into the heel. And basically into the bottom of the heel, and then you kind of move that needle around. That sounds gruesome, but basically you do that so it creates a bleeding in there. And what we want to do is trick the body into thinking something damaged, something bad happened, so that she resets that clock, she pours out all of those healing tissues, and then you've got a chance to get this done. This has been really successful on ankles. Ankles that I've had with patients had bad chronic ankles for long periods of time. This is absolutely phenomenal. In the heel, I haven't got my technique as well as I want. I can't predict as well as I can. Fenestration is a lot the same, but I think that if I could figure out a way on this injection of the heel portion of it, the thing is that this is a little less traumatic to the patient. you know, because you're not going in there and stabbing the heel, and you don't have to discuss that. You're going to say, well, I'm going to give you a shot, and we're going to fix you up, and that's a lot less, you know, traumatic. But as long as it works, that's all that counts. But this is promising. Pain on pain is another way of treating this, and what we do here is when someone has long-standing pain for long periods of time, you take local anesthetic and you go higher up in the area of the nerves, and you put it to sleep. And you put it to sleep by letting it stay asleep for about 72 hours. Basically, you're using long-term Novocaine into the area, so you block out what's just called pain on pain cycle. Because once you get into a pain cycle, like a headache, you know, the headache creates more, more. And so the thing is what you're trying to do here is to block out that pain cycle so that Mother Nature can then come in and reestablish herself and kind of get the pain pathways to work a little bit better. And this has been, like I say, this has been used for years, you know, in pain clinics. Other things are osteotrons, cryotherapy, endoscopy. These are ones, basically, osteotrons are where you bounce high and low frequency waves into the heel. That's being done now. It's not any better than any other thing that we have. The cryotherapy is where you take frozen rods and you run through the heel. That's kind of fallen out, but that's still in practice. The endoscopic is really where you take an arthroscopy and you run it into there and you cut the plantar fascia, and that's probably one of the more popular ones now. But thinking in terms of what you're trying to do here is that they're trying to cut the plantar fascia, but you have knowledge today that says, what are they trying to do? They're trying to reset the clock, and they don't even know it, because that's not why people cut the plantar fascia. But cutting the plantar fascia has been around for centuries. But the problem with it is it creates like a pencil feeling on the bottom of the heel, and it becomes very irritating after walking. And so what it is this is a way of resetting the clock. And so if you just went in there and nicked the plantar fascia, you'd reset the clock and you'd have a result. Here is cutting the plantar fascia and then cutting out the heel spur. You can do those things, but I think the thing is you need to be prepared for a long-term recovery time. So remember this, key factors, okay? Early treatment, early recovery. You want to maximize that healing tissue. You want to stop that continued trauma to the heel, and there's no magic wands. I don't care what they are. I've been in practice for umpteen years, and I have yet to find the magic wand. But I remember that early treatment gets you fast results, and long-term treatment gets you long-time results. I thank you very much for your patience and tolerance, and I hope that we have something here that you can take home with you and see a benefit. Remember, ice, elevation, and rest.
Are the condition of the nails, the toenails included like if you have problems with your toenails, is it the podiatrists?
Well, let me say that, the thing is, any time that you have any kind of problem with your foot, whether it be, toenail problems or corn problems or callus problems and like that, it will have an effect on it. And if I understand your question correctly, is that will alter the way that you walk. Let's say your toenails hurt and you start walking differently. Any time that you put that stress on that plantar fascia, which we kind of determined is a narrow slip that fans out to a broad area, you're going to put some stress on that area. And when you put stress on that area, you're going to have some problems, and you're going to have some potential problems. So to answer your question is, yes, it's very possible. It's not the main cause, because again, it's the hard surfaces that we walk on, the trauma to the heel is the main cause, but that's certainly a contributing factor.
Can you give us any brand of heel support or something that we can put
in your shoe?
Brand, what kind of brand?
Sole is one. But I hesitate. What I want to give you here is a concept. What you do is you go down there, and Dr. Scholl's has some great ones. And what you do is you go down there and you say, okay, when I went to this seminar, Dr. Johnson said, I got to elevate my heel, I got to cushion my heel, and I've got to give myself a little bit of arch support, to support it. So whatever they sell on the market today, those are ones. And so then what you do is you put it down on the ground and you step on it, and your body says, yeah, that feels pretty good. Then that's the one you buy. Unless you get thrown out of the store for not, for stepping on it. But those are your concepts. The brands I don't think are as important because those change all the time. And if you get into just a good running shoe, like that light and easy running shoe, that's a great little shoe. For $14. I mean, after you get through with that one, you can throw it away and you go buy yourself a new one, right?
When you tape your foot, how long do you leave it there? How many hours?
Oh, that's a good question. What we do is, I would say to you, is leave it on initially what you want to do with that. Now, and if you don't have tape, get yourself some masking tape or duct tape or anything like that. But what you do with it is you leave it on there generally for a week. Then you take it off. Now, when you initially start to tape, it's good to have somebody tape it for you, and you kind of teach them if you can. But I would say to you probably 5 days, then take it off, take a bath or shower, then put it back on. You're not going to get better with just one taping. It's going to take you several tapings to get better. So to answer your question is, I'd leave it on for 5 days, take it off, take a bath or shower, then put it back on for another 5 days. Then after the second week, then I'd see how you feel and how it's progressing. At the same time, after you tape it, go into like a running shoe, a soft, elevated heeled shoe to support it along with it.
You said you have to start with the soft orthotics.
Yes.
And then you progress yourself to the hard orthotics for later.
Yeah.
And then, so for how long then?
Now, what you do, and orthotics are the jazzy word for arch supports. So if you think of orthotics, think of arch supports. And the thing is, what you do with it is this: you stay with the soft one for, I would say, 4 to 6 weeks period of time. Because I think it's going to take you that long. In other words, you're going to make a determination within a matter of 2 weeks' time whether you're getting better. If you're getting better, then stay with what you're doing. And so 4 to 6 weeks period of time, I would stay with that soft. Then what you can do is go buy yourself a little more firmer type of an orthotic, but also covering it over the top with something like Spenco or something soft. Remembering that this area is very tender. I mean, this bone has been bruised, and so you have to keep it cushioned. So even when you go from the softer orthotic to the little firmer orthotic, be sure and cover it with a covering or make sure that it's soft for 4 to 6. Then after that, then you stay with the orthotic for a longer period of time, because really, we put patients in orthotics, as Pat knows, and the thing is that you'll wear them for a long time.
I have a fungus nails, as well as I believe I also have neuropathy in my toes.
Mm-hmm.
Hasn't been fully diagnosed, but it feels that way, and I've been using some medication for the fungus on the toes.
Uh-huh.
I was just wondering what would you recommend for something of that nature?
Oh, with a fungus on the toes and the neuropathy? Fungal toenails are really common. People have them. What I use in the office, and I tell everybody to do, is use white vinegar. Get yourself a bottle of white vinegar, just grocery store variety, the $1.50 in the gallon. What you do is you put it in a spray bottle, and then after you take a bath or shower, while you spray the tops of your nails, once in a while take a little emery board and buff the top of it so it becomes more penetrable. The reason you have the fungus is because you've lost the acid mantle or the acid condition of your nail, and so then the fungus can get a hold of you. But you have to use, if you use the white vinegar over that period of time, it will take you probably a couple of years to kill it, but at least it won't get progressively worse. If you feel that you have neuropathy, you need to have that checked out, number one. But there are some things that you can do, for the neuropathy. One of the things is like Zostrix. That's a cream that you can apply on it. You can also get B6, B12, and lipoic acid. And that's been really promising for patients. And basically, what you do is you take this orally, And what it helps is if you do have a true neuropathy, it does seem to lessen that neuropathy by a whole bunch. The combination of the B6, B12, and lipoic acid. And if you want to call the office, I'll give you the girls will give you the percentages and how to do it. Because what happens is you take it at one level, and if it kind of doesn't do the trick, you go to the second level. If it doesn't do that, you go to the third level. That's been really promising. Also, you want to get some B12, Trader Joe's, and get the sublingual, and you dissolve it underneath your tongue. And what it does is it has a somewhat a soothing effect to the nerves, and it does help, with that neuropathy. But on the other hand, is that you need to there's a test that you have now that helps us to differentiate between the tarsal tunnel we talked about here, where there's a compression on that nerve, a true neuropathy, or whether it comes from the back. The thing is that this test has been really beneficial, because we used to lump all of neuropathies together and we'd say, well, you got a neuropathy, that's the way it is. Well, what happens with it is that you need to isolate what kind it is, because if, let's say that you have a tarsal tunnel, it will mimic a diabetic neuropathy when you can inject the ankle, treat the heel, get rid of the neuropathy, and it's almost overnight. It's just dramatic. Now, otherwise, we just said, well, you had to live with it. But try the B6, try the lipoic acid and B12, and make sure the B12 is sublingual under the tongue, because your body doesn't absorb it well from the intestinal tract without what we call intrinsic factor. And so what happens with that is that helps that neuropathy tremendously. Yeah, all of those you can purchase over the counter.
Hi, I think I have plantar fasciitis. That's what the doctor told me. But I did not have any x-ray. He just looked at it, and then he gave me a cortisone shot. That was last May 2009. So that was in the morning. So that same day, the pain was gone. And that was in May, and then I traveled to Grand Canyon, and after I came back, I had it again, the pain in my heels. So my question is, I just want to do another travel, and will I be able to walk to do it with my plantar fasciitis? Because right now I haven't seen the doctor again, but what I do, I just roll my foot on that cold juice,
Let me say this, what happens if you went and had another cortisone shot, it wouldn't help you. Because
it will not help me?
No. Because the thing is what happens with cortisone is we have an injection of cortisone. The next time you have it, you only get half of the results, and the next time you get only half of the results. See, what we're saying here to you today is you have plantar fasciitis. Now, each time that you have an injection of cortisone, you take away Mother Nature's healing tissue. So you got to be careful. So you don't want to do that. I don't want to criticize anybody. I don't mean to say that. But the thing is, in my viewpoint, is that you have, you lessen it. So each time that you get a cortisone shot, it lessens it by that much, to the point that you've depleted the fat pad. Remember the ballases? The more of those cortisone shots you get, the more softening of the ballases and the greater the tendencies for the rupture of the ballasing. So now you're walking on the bone. We see that all the time. What you have to do is go back and see your doctor and say, I want to treat the cause. I don't want to treat the symptoms. You're treating the symptoms, because the next time you get it, instead of lasting for a month, it'll only last 2 weeks. Then the next shot will only last a week, and then it won't do anything. Because see, it's really not inflammation in your case. You've had it long enough that you've torn the fibers, and you have to go back in. And what I would do if for you is start taping your heel. You start taping your heel. Wear a soft shoe. But realizing, because of the length of time that you've had this, it's going to take you a year to get this better. There's no magic. It's going to take you a year to get this better because you don't have a lot of healing tissue in there. Mother Nature said, I'm sorry, I gave you a period of time to get this better, and so I'm not going to pump any more of my healing tissue down there. So you don't have that. You're running off of whatever's left over. And so you have, but if you keep walking on it like you're doing, you're tearing those fibers, you're micro-tearing them. And so you have to be really careful with that. But on the other hand, you got to do something. And so what you want to do with that is you want to elevate your heel. You want to go to a soft running shoe. Go down, buy yourself a Big 5 light and easy. You want to get your next door neighbor to tape your foot up as tight as you can. And then you want to get a soft arch support and you want to wear it. Or you want to go down and buy a pair of cowboy boots and start wearing the cowboy boots. You know?
Because right now, even if I just go grocery shopping.
Sure. You have no idea how bad it's going to get. It hurts all the time, and it's only going to progressively get better. So cortisone, remember, if I tell you nothing else, is that there's no magic. And you have to be responsible to a certain degree for your own care and your own management. You have to direct that. Because the thing is what the shot's not going to do it. It won't double the length, it shortens. Because the shot is not treating the cause. It's treating the symptoms. Does that kind of make sense?
Can I continue with my exercise, like walking?
If it hurts, I wouldn't do it. You know, what I would do with it is this. If you want to exercise, you want to go to cycling, you want to go to swimming, and you want to go to an elliptical. But I wouldn't impact that heel in your late stage, because the thing is you don't have a lot of help. So what you want to do is you want to go to cushion elevation and be careful.
Okay, we have time for one more, and I don't know if you have time to stay to
Sure,
answer
I
questions
sure.
afterwards.
Sure.
Here's our last question.
Sometimes when I walk, my arch hurts. What happened? How do I prevent it?
What that is that you have that kind of that early stage is where the arch is changing. The arch is actually falling. And you're getting a compression of that arch. And as that arch compresses, the inside part of the arch of the plantar fascia is kind of pulling. So what you're doing is your arch is giving way just a little bit. You need to be in an orthotic so that you can, so it will support that, so it won't progressively develop and eventually end up with heel pain or arch pain or mid-arch pain. You need to get in an arch support and or a good running shoe. So what I do is do both, get an arch support and running shoe. Cover it.
Well, let's thank Dr. Johnson.
Yeah. Thank you.